Again, we're dealing with this particular case of COVID. The case is sudden, severe, fatal case of COVID. The patient gets the COVID, goes to the hospital, gets intubated. In less than 1.5 to 2 weeks, the patient's dead. So that's the case. Probably, of course, we won't try to explain. It could be all sorts of things. We know it happens many times. I mean, it's not the most common course. The most common course is you get better and you don't get a ventilator. That's the most common course. But this is the course that ends in death. That's sudden and severe. So that's this particular case. It is more common, especially in places where it's harder to access the health delivery system, or the health care delivery system is getting overwhelmed. So by the time people realize that you're really sick and you need a ventilator, well, that's the time you get into the hospital, and then you guys are trainees in the academic medical centers would end up seeing them, and then that's your point of interaction. So these are a lot of the cases that you're seeing. Of course, these are not the most common cases. If you look at the community, or you look at the society or the country at large, I mean, it's not like it's 100% fatal. So that's the case. So now we're going to deal with the last 60 minutes. So the last 1 to 2 hours of life. You can even extend it to 3 hours. But then definitely the last 30 minutes to 60 minutes, that's what we're looking at. So someone's about to die, and we're going to limit our focus. We're going to limit our focus on the patient. Okay, so we're going to touch on a little bit about the family and the doctor and the healthcare providers, the nurses and the doctors in the hospital who are about to see and witness the death and experience the death. But right now, the main focus would be the patient who's dying. This is his show. I mean, he's the one who's dying. I mean, everyone else would live through it, the experience, and then go on with their lives. So we're going to focus on this particular case, the patient. Nobody talks about it. Even if you scour the entire literature, I mean, who would talk about the last 60 minutes before death, or last 60 minutes before you lose consciousness, the last few hours or few minutes? I mean, for one thing, what do you say, right? I mean, it's not as if we know a lot. We don't do surveys on people who are about to die in 30 minutes. We would have an idea if we start interviewing people, and it's doable, or we start interviewing family members who were with the patients during those times. But then, of course, the question is, in what context? In the COVID ward, there's no family member. So how do we figure things out? Well, to be honest, I can't really tell you. I mean, definitely the context would play some role in this death event. So this is a different context. You're away from your family, and there's a lot of things happening which don't happen in the usual course of a sudden, severe, fatal hospitalization that's not COVID. I mean, the isolation is a big deal. The other big deal is people have been talking about COVID for the past 1.5 years, or almost 1.5 years. So there's a sense of fear, anxiety, even before you got COVID. And there's all sorts of things going on even right now. I mean, this patient might be participating in some kind of political argument in social media before he got the COVID. So he has his own ideas on who's at fault and things like that. Everybody is sort of an expert, and your perceptions and thoughts would play an important role in how you die, or what happens to you, or how you experience the final minutes of your life. It's very personal, and that's the topic of, I think, the second video. So my suggestion is you watch the first and the second video before watching this. This is going deeply into it. This is more subjective, personal, and less established ground. I mean, we won't cover a lot of ground in this territory, but we'll try to make sense out of it, because at least we should have some kind of an idea. We should care about what happens. I mean, the patient's still a person. He's still alive before we take out his consciousness, or if his consciousness disappears by the time of his biological death. He's still a person. Stuff still happening in his brain before his brain stops working because of his brain shutting down, or because of electrolytes or oxygen levels and things like that, right? So you take care of the person until the very end, of course. That's the idea. Now, before we leave the doctors and the family behind, let's consider everyone else around the patient's not dying. The doctors, the nurses, the pastoral care provider, the clinical counseling person, whoever that is. If that's not the hospice person, or if that's not a psychiatrist, or if it's a clinical, whoever's around the patient who's experiencing the death event, present around the patient during the last few minutes or last few hours of his life. The experience is different, right? The effect on the family member would depend on how close the family member is. The patient's life is not his life. The attachment of the family member to the patient is the life shared with the patient. And definitely that's much less than the person who actually lived the life. The relationship is the one that's being lost by the family member. So definitely this family member will go home affected by the death, close relationship like a spouse or a mother of a child. And that's really severe. One of the hardest things to accept for parents, especially for moms, would be the death of the child. I mean, it's so hard to think of experiences that would top that. I mean, the kind of suffering most moms will experience. That's so hard. And we should keep that in mind, especially if we're talking to moms and trying to force them or make them decide right away to go home and accept the situation and things like that. That's not an easy thing. Then again, you shouldn't get irritated because that's cruel, right? Even if you justify it by some nebulous idea of justice, like you're in this hospital, there's so many people who want to go in, and let's say it's not COVID, so of course if it's COVID you cannot send them home. You're telling the mom, just go home. There's nothing for us to do. And then the mom doesn't seem like she's accepting the situation. It doesn't seem like she's thinking straight. Well, it's a lot of emotions. Just think about it when you're the parent of a kid who's dying. How would you feel? Now, of course, the problem is we don't think that way. We don't try to empathize and we don't try to understand. Now, the doctor would also be strongly affected. I mean, it's not as if the doctor's not affected. The doctor would also be strongly affected. I do ask people a lot of weird questions, especially people I know. So what's the most traumatic case you've ever handled? The top 6. And guaranteed that one of those top cases would be the first few cases where their patient died. Why? Well, there's lots of things. We feel responsible. The way we're training you is like if the patient dies or something happens to them, you go up there in the morning and endorse, and then a lot of older people around you, the senior residents, maybe the chief resident or the consultants, might gang up on you. Like, what did you do wrong? And so you feel responsible. Like this patient died or this patient became an invalid because of you. You're not smart enough. You didn't read enough. You didn't do the right thing. And people actually go into post-traumatic stress. Yeah, it does happen. I've seen it. So, I mean, I've also went through school. And so when you grow up, you're already grown up. So when you're already on your own and you're fully responsible, there's no supervisor who's responsible aside from you. Although sometimes it feels that way, that you're still a trainee, you have a supervisor, but it feels like people think you're the one responsible for whatever bad thing happens. But when you're officially, legally the doctor, that's how you think. And so you do your best to make this patient better, and then you try your best, and especially in the first few years of practice. I mean, you're a fresh graduate. I mean, you think you can save the world, right? And then suddenly, no matter what you do, the patient dies. No matter what you do, the patient starts dying, and you cannot tell the patient to go away, go home. I mean, you're the doctor, and the patient's still in the hospital. Especially if the patient is in a private hospital, you cannot just say, go home and accept their fate. It can definitely be unethical or maybe illegal to do certain things, especially if the patient is really sick and about to die, to just send him home and go in without any form of anything, or knowing that they'll probably end up getting worse on the way home. So assuming that's not the case and you're doing your best and the patient dies, will you experience that? Of course you'll experience that, especially if you're handling people who are sick enough, who needs to get admitted in the hospital. Why? Because you're not God. You're not even a demigod, right? And death is part of life. I mean, no matter how smart or how good you are, no matter how lucky you are, one of these days, one of your patients or all of your patients will die. And if you're still their doctor, then you'll get to experience taking care of them while they're dying and when they die. And if you're unprepared for that, and you've only had 2 weeks, and during those 2 weeks you just paid attention to pain control, advanced care planning, and they go home, and then they call you up in the middle of the night. The nurse says your patient's dead. I mean, that's the only thing you've had in your training. Well, it can be very traumatic or very stressful that your consultants, or a lot of them, would actually remember those cases
for at least a few months or a few years. The most memorable, difficult case they've ever had, or the most memorable, traumatic and most difficult cases they've ever had. They can probably even visualize the faces of those patients, how they looked at them during the time they're about to die, for at least a few weeks or a few days, or even the sound of their voices, especially if they're really into it. When it looks like he can do it, and it looks like he can cure the patient, and the patient starts dying, who would forget that? Before we leave that topic, because I promise we'll focus on the patient. Take home point, you're not God. Death is a part of life. No matter how smart you are, the patient will die. And you're not perfect. Even the doctors or the seniors or the consultants, whoever they are, asking from the back when you're standing there for your mortality, morbidity presentation, probably made several errors during their practice also. So it's not like they're perfect and you're not, and there's something wrong with you. That's really not true. Although you feel that that's the case when you're standing up there in front of everyone, getting grilled and getting eaten up alive. So just survive, and hopefully the situation and the training changes or improves further down the road. I'm not sure whether it's better right now. It has like seasons, like there's a bad season and a good, depending on who's sitting and who's asking, or depending on who the asking people are. Good years and bad years, as far as trainee stress and sense of failure is concerned, or a sense of unworthiness is concerned. So now consider you're the main character in our story. You're the person lying down on the bed, on the ventilator, and rapidly deteriorating, and all the doctors and the nurses and everyone inside the hospital who knows about your case know that you'll probably die in a few minutes or a few hours. That's pretty much it. Or you'll probably die tomorrow, and it's time to knock out your consciousness, and you won't be aware, you won't be conscious during the time of your death. So pretty much the disappearance of your awareness in death happens when they send you into a deep slumber. You pray that they really sedate you that deeply. The worst thing that can happen to anyone who's dying would be someone gets sedated but not deep enough, and you're actually aware, but you're chemically unable to express yourself. You just know that there's something happening to you. You can hear people around you, and you can't move. All you can do is croak, and you feel confused because your brain is all clouded up. That's the worst kinds of sedation with death. Somewhat sedated deeply enough so as not to cause any irritation or trouble to everyone. You're just there, you're lying, you're looking up, and then your face might be grimacing a little bit. Hopefully not, but peaceful enough for everyone to feel peaceful also. The family likes the idea. You're just lying down there. It's almost like you're sleeping, just waiting for your vital signs to go away. But there's almost no difference between you with no vital signs and you sleeping right now, except that you're breathing and you still have a pulse, right? The doctors and the nurses will also find that peaceful because, they don't need to get called by the family member that you're in pain or grimacing and you're moaning, and then they're worried. Now, of course, if it's a COVID ward, there's no family calling the doctor. It's just you moving about, and the doctors are not even rounding, so that might not be a problem for everyone. They probably won't get too troubled, but there's even a plastic covering around you. So, it's hard to see slight traces of grimace and suffering and distress on your part. And they even have a face shield. How can you see a really subtle grimace, especially if someone has muscle relaxants or medications to paralyze and medications to sedate him or drug him out? The worst thing that might happen is you actually conscious enough to know there's something happening to you, and conscious enough to know that you're about to die. And you might even be feeling some pain, you just can't express it. That's bad. So take home point, if you're going to sedate someone, make sure you do it right. Imagine if you're that person. That's not the kind of thing you want to experience, right? The last few minutes and last few hours would be experienced based on the awareness. When did you know that you're about to die in a few minutes? Or when did you know that you're about to die in a few hours? Like for sure. Or when did you know that you're about to be sedated? they're going to put you to sleep and you won't be aware. You'll be knocked out completely, or so you're hoping. You either don't wake up or you wake up someplace else, if that's your belief, right? So, but this is your last sense of consciousness and awareness in this planet. That's the time you start thinking about disappearing from this planet, the end of your life, also known as death. That's the time you start thinking about death. In a lot of Western or Westernized places, institutions, medical centers, academic medical centers, modern Westernized societies, a lot of times you don't get told right away. There's a sort of a conspiracy between the family who's trying to protect you, and they're thinking, once you know, then you die earlier. That's a very common belief, actually. That's one of the reasons why people don't want their family members to get told. Once they know, they die faster. There's this idea that knowledge that we're dying will actually make us die. You don't think about it, so that doesn't happen to you. People don't get screened for cancer, even if they're symptomatic. So it's not like an annual screening test. You're actually feeling something, and it looks like, you definitely, if you want to live long, you want to get screened. They don't want to get screened because what if it's positive and you know that you have cancer? The knowledge that you have something that's probably fatal. So the knowledge itself makes you die. Yeah. I would guess that actually goes back a long way. Even ancient communities and ancient belief systems, thinking about it makes you die faster. And we do that ourselves. So, or the more common reason is people want to protect their family members. They'll be depressed, they'll be sad, and we want him or her to be happy. They're already dying, and we shouldn't do that to this person. Even doctors feel that way, right? They withhold. It's good if you don't do it too long, and it's bad if it prevents the patient from preparing himself. It's bad also for you guys, the family and the doctors and the nurses, because you also are not preparing for it. What you'll end up doing, what you should not be doing when the time comes. Like, I even see the doctors and the nurses thinking about correcting the potassium and the electrolytes when obviously the patient's dying and the kidney is about to fail. No amount of correction isn't going to make that electrolyte go anywhere, right? So obviously this person's going to die. Multi-organ failure, that's what death is, right? Your body begins to shut down and your organs begin to shut down. And, the kidney shutting down, let's call the nephrologist. Maybe you can do a dialysis. Of course, an outsider. Sometimes, because I think differently, would say, oh, what are you talking about? This person is dying. Why would you do that? Doesn't make sense. You see that a lot. The patient's dying, everybody knows he's dying. Even the doctors know that they're dying. And then the creatinine comes up and then, it's very high. Maybe we can do dialysis. And first the question is, what are you talking about? This person's about to die in 2 to 3 days, right? Well, yeah. But the creatinine it's like reflex. Can you even start dialysis? No. Then why are you bothering the nephrologist and the dialysis guy? And the reason for that is nobody wants to think about that. Even the doctors ordering the stuff. We really don't know what we should be doing. In that time, which is like a crisis mode for everyone, very stressful for everyone, you do what you usually do. And usually when you see a bad kidney function, you do what you usually do, except that the rules change during the last few minutes to hours of life. So that's the take-home point. The rules change because you cannot make the person live any longer. So the stuff that you do that's aimed at making the person live longer or curing the patient, prolonging the life, doesn't work anymore. You have to swallow that. You don't just keep on doing it until the very end. Then, like maybe a miracle will happen. You're no different from someone who's just praying for a miracle, right? So stop doing that. And then the other rule, once you accept that the person is dying, is the goals change. So you cannot prolong the life too much. You cannot cure the patient. The patient's going to die. So what's the goal? Well, maybe the goal is the patient dies with significantly less distress, right? To decrease some of the suffering as much as the patient wants, or to make sure that the patient dies a peaceful death. But this is the bottom line. Even if you don't tell the patient will know. Why? Because the verbally communicated information is not the only information they're getting, right? So the way people behave, the way their families behave, the non-verbals, their facial expression, the way the doctors act, the way they order stuff. Suddenly they're ordering, before they were ordering a lot of tests, and everything's more rapid. They're trying to do stuff because they see your kidney and they see your heart and see your lungs, and they're trying to head it off, and suddenly they're not doing as much anymore. And people are even asking you about advanced care planning. So even if they don't tell you, right, they tell you not to think about it. Even if they don't tell you, you can take the hint, right? Even if you don't see the clues or the hints, your body will tell you. So you're feeling different. You're feeling weaker and weaker and weaker. Suddenly you're not as aware as before. Your consciousness is going down. Now for COVID, there's another thing that tells you. I mean, even before you got sick, you've been listening to the stories about COVID, about people dying in COVID, and about what happens to people who get ventilators, right? So, and the fact that they're about to put you on a ventilator or put you to sleep tells you you might not wake up. Or even if you're awake, somewhat awake while you're on a ventilator. Not everyone gets sedated that deeply on a ventilator. That means something. A lot of people are more knowledgeable right now about COVID than before, right? Because it's all over social media and internet and the news. So the fact that they're preparing the ventilator and they put you on a ventilator, it makes you start being aware that you might actually die. Death awareness. Now, of course, you're aware, they're aware, but they don't want you to talk about it. You might not even want to talk about it much because the thought is difficult for you to accept. Everybody knows, but you pretend that you don't know. Don't bother us death, and you don't want to get stressed. Mutual pretension. You pretend that you don't know. Now, of course, the ideal, the one everybody's being told, is open awareness. The mental health, psychologists, psychiatrists, counselors, hospice doctors, palliative care doctors, or pastoral care providers, because the obvious being out in the open helps a couple of things. It facilitates the decision making. You can support each other. You can help each other prepare. You can tell your family members what you want and what you don't want. You can finish some of your unfinished businesses, the things you want to do before you die. Okay, that's unfinished business. We won't go too much into that. That's another session. They can even call the priest, and and then you can talk about death and the afterlife and things like that. Your pastor or your pastoral care provider can do that if your doctors and nurses are uncomfortable about that kind of thing. Or even your hospice providers. Just because they're hospice providers, it doesn't mean they're religious. Not right now. I mean, hospice and palliative care already went mainstream. It became medicalized. Unfortunately, for most disciplines, that's the way to get accepted in a not too ideal, maybe some people would call it corrupted medical system with its own medical philosophy. It became medicalized, and people went into the field who are not very religious. And you can imagine if you're not very religious and you think like everyone else, emotion is nice and religion is nice, but they're not real or they're not important, especially religion and spirituality, then you can guess how much focus and resources are going to get poured into that. So that's awareness.